All right, good morning, everybody. Welcome to Pediatric Grand Rounds. Thanks so much for those of you who are in the room with us, and welcome to our new interns who I think started yesterday. So we really are excited to have a new year with you. And for the interns and all the residents, if you have any suggestions for a Grand Round topic, I'm the person to talk to. So come find me afterwards. I think this will be a great starter Grand Rounds for the year. And for those of you online with us, thanks for being here. Just the usual reminders to make sure you're muted. And I will be watching the chat box for questions. So if you have questions, you can feel free to type those in at any time. And now I have the pleasure of introducing our speaker, who is virtual for today, and I really appreciate her time. This is Dr. Jessica Hauser-Chatterjee. She's an assistant professor of neurology at the University of Washington and an attending pediatric neurologist here at Seattle Children's. She leads clinical and research efforts in pediatric headache medicine, including founding Seattle Children's Pediatric Intracranial Hypertension Clinic and establishing nerve blocks as a treatment option for children with headache in Seattle. Dr. Hauser-Chatterjee is a principal investigator at the Seattle Children's Research Institute, where her work focuses on better understanding the pathophysiology of migraine. She is a recipient of the American Headache Society's Frontiers in Headaches Research Award and the ITHS Early Investigator Catalyst Award. She's a dedicated pediatric neurologist, educator, and passionate about improving care and education for youth with migraine. So excited to have you here with us. Welcome, Dr. Hauser-Chatterjee. Thank you so much.
All right, great. Thank you so much for that introduction. My name is Jessica Hauser-Chatterjee. I'm a pediatric neurologist with special interest in headache medicine, and I'm going to be talking about pediatric migraine pathophysiology, and with the goal of communicating that migraine is not just a headache. And welcome to all of the new interns. I want you to imagine your first rotation in the emergency department or in clinic, and you see a patient, and maybe you're seeing them for an ear infection, or maybe they're there for their sports physical, and they mention to you, or you hear something about them missing school because of their headaches. Now, I really want to empower you to ask more questions because most likely they're experiencing migraine and they would benefit from being diagnosed. And so here are my disclosures. And I just need to say that nearly all medications for the treatment of migraine are considered off-label use. And I'm a speaker for the American Headache Society First Contact in Pediatrics. And some of those slides are from those talks. So here are my learning objectives for today. After looking at this slide, I remembered how it's more important to keep things simple. So kind of breaking this down a little in more simple terms, my goal is for you to walk away knowing the difference between migraine in kids and adults. I want you to be empowered to diagnose migraine in youth and know what kinds of resources are out there to help you diagnose this. And then also have an idea of some of the first steps after you diagnose migraine. And then I want to talk about what's new in headache medicine and how this is going to transform pediatric headache care in the future. And really my goal is to make some of the current science clinically relevant. And so here is an outline for today. We're going to talk about what is migraine. We'll go over the phases of a migraine attack, the physiology, and the future of headache medicine. So first, let's talk about what is migraine. And if you're like me, you may have thought that migraine is just a really bad headache. And that is true, but there's so much more to what migraine is. And so if you have a parent that has migraine, there's about a 50% chance that you will have migraine. And all of the symptoms that are associated with a migraine attack, the light sensitivity, the sound sensitivity, the nausea, the dizziness, the cognitive symptoms, those are as much a part of the migraine as the headache pain itself. And so as a definition, we consider this an inherited disorder, a largely inherited disorder characterized by attacks that include a variety of neurological, gastrointestinal symptoms with or without severe headache. And we'll go into this in a little bit more detail. So who has migraine? This is a pediatric talk, so clearly children have migraine, but I want you to know that over 1 billion people in the world have migraine, and that works out to about 10% of kids. And then 1 out of 5 women and 1 in 16 men. As you can see, before puberty, uh, you know, after puberty, there's many more women than men that have migraine, but before puberty, the distribution is about 50-50. And so the mean age of onset in migraine for boys is about 8 years of age. And for girls and females, it's 9 years of age. So before puberty, there's going to be a time where it's more common to diagnose this in males. What does that mean for Seattle and the metropolitan area? So I just wanted to kind of bring these numbers home. And this is some recent data about the population of Seattle. And so if we look at the population of children under the age of 19, we're looking at, in Seattle, at least 11,000 children with migraine. And in the metropolitan area, over 80,000 children with migraine. And this is going to be very common. You're going to see this almost every day. And compared to other pediatric disorders, it's right up there. If you think about ADHD, ear infections. So migraine is twice as common as ear infections. So this is something that, is people are going to be coming in to the clinic, and they might be coming in for an ear infection, and they might just make a comment about their migraine, but these are things that you're going to see in clinic. And we have evidence that it can really affect the lives of kids. So kids that have headache are more likely to miss days of school. They're more likely to have school reported problems and more likely to repeat a grade. In fact, over 130,000 school days are missed every 2 weeks because of pediatric migraine. And so I'm going to just say that we have a window of time where we can make a huge influence on the quality of these kids' lives and their futures. Migraine is the leading cause of neurological disability in children over the age of 10. And so here, what we're looking at is years lost to disability by the thousands. And the green is migraine. And this is actually throughout lifetime. And in migraine is the leading cause of disability worldwide in the 15 to 49 age group. And then, before 10, while migraine is still there, idiopathic epilepsy is the leading cause before 10 of neurological disability. Okay, so we've talked about the definition, who has migraine and how prevalent it is. And let's talk about the diagnosis. And in 2019, the American Academy of Neurology and the American Headache Society put out their practice guidelines, an update on the acute treatment of migraine in youth. And their number one practice recommendation is to establish a specific headache diagnosis. And so how do we do that? I want you to know that this is a resource available to everyone, but there is an International Classification of Headache Disorders, or ICHD3.org, and the International Headache Society has a group that defines every type of headache. Primary headaches, secondary headaches, all types of head pain and neuralgias. And it's not a great read from beginning to end, but it's a great resource to look at the diagnostic criteria for all of these headache types. And they published this, the last was in 2013, and I can tell you that they're already working on the fourth iteration of this. So how do we diagnose migraine in pediatrics? So this is, I had permission to highlight the pediatric components. So in order to be diagnosed with migraine, you have to have had at least 5 attacks filling these criteria B through D. So you have a headache that lasts 2 to 72 hours. Now, if you fall asleep with a headache and you wake up and it's gone, you count the entire time you're sleeping as part of the headache. Other things, so for criterion C, the headache has to have at least two of the following four characteristics. Now, in adults, a unilateral head pain location is most common, but in 50 to 80% of kids, a bilateral frontotemporal location is the most common area for having the headache pain. The pain is often described as a pulsating quality, moderate or severe intensity, and aggravated or causing avoidance of routine physical activity. And for kids, that could be missing soccer practice, missing school. And then you have to have at least one in this category. So during the headache, you have to have at least one of the following. You can be nauseous, you don't have to throw up, or you have light and sound sensitivity. And I've never had a 7-year-old walk in and say, I have phonophobia and photophobia, but we can infer from their behavior that they have these things because they prefer to be in a quiet, dark room, or they tell everyone that they're being really loud. And then every single one has this component that it's not better accounted for by another diagnosis. So again, you only need 2 out of these 4 and 1 out of these 2. Now, if you don't meet all of these criteria, then you could be diagnosed with probable migraine. And, and I'll go into a little bit about some of the work that some of our pediatric colleagues are doing to help capture all of the kids that have migraine. This slide, I'm highlighting those differences between adult and pediatric headache. And so the number of the attacks needs to be the same. The duration is shorter. It's more common to be bilateral in pediatrics. And then we can infer from behavior, light and sound sensitivity. Now, of these 4 categories, what is the most common reason why kids don't meet the full criteria? And so a group at the Children's Hospital of Philadelphia and Cincinnati Children's developed a cluster analysis of migraine-associated symptoms. And this is a way of critically appraising how these diagnostic criteria actually capture children that have migraine. And all of these criterion, they're really helpful for developing clinical trials. But like I mentioned, all of those other symptoms are as much a part of the migraine as the headache pain. So the number one reason why kids are not meeting the full criteria is because of criterion D. And so if you remember, that one is having photophobia and phonophobia, or nausea or vomiting. And so they looked at almost 9,000 youth and looked at the ones that met probable migraine criteria. And they found that using this analysis, if they changed the criteria to photophobia or phonophobia, they were much more likely to capture children that truly have migraine. And so the criterion D is the number one cause why kids are not meeting the full criteria for migraine. And they're proposing to the International Headache Committee to consider casting a wider net in order to help us diagnose migraine earlier. They also highlighted that there's a number of other features that are associated with migraine that are not, that cluster together. For example, lightheadedness, spinning, ear ringing, visual changes. These are associated with migraine and part of the migraine, but they're not part of the criteria. And if you see here, what we're looking at is the ICHD symptoms, and you see vomiting, nausea, light and sound sensitivity. And then these are often associated with having migraine, but they're not part of the criterion. Osmophobia is up here under ICHD symptoms. It was actually part of the diagnostic criteria in the second iteration, but since what they found was almost everyone who had smell sensitivity also had light and sound sensitivity, they made that change. So I want you to recognize that there's no perfect diagnostic criteria and that this is a work in progress. And the hope of this group is to really use evidence-based, data-driven information for the next iteration of the ICHD-4. Also, if you look under the ICHD website, there are a number of episodic syndromes that are associated with migraine, and they have their own classification. And these are things that we're going to see in pediatrics. They include things like colic, benign paroxysmal torticollis, benign paroxysmal vertigo, cyclic vomiting syndrome, and abdominal migraine. Now, colic is something that can present 3 weeks after birth and is characterized by crying for long periods of time, for at least 3 hours a day, for at least 3 weeks. And there is, if in someone who has migraine, they were 7 times more likely to have had colic as a baby. Another thing to know is that mothers that have migraine are more likely to have children with colic. And the mother's migraine frequency is associated with that increased risk. And so I think what you can think about is when you have a migraine, your brain is turning up the volume on all of these sensory experiences. So then, things that aren't normally painful become painful, like light and sound, touch, smell. And in babies that have colic, you could imagine that they are hypersensitive to their surroundings. And these are things that you can also help when you see children in your clinic and the family is describing, something that clearly is colic. You could ask about a migraine history in mom, and then you could also, reassure them that this is something that is seen in individuals and in parents that have migraine. So this is just another way of showing this. These childhood syndromes that may be associated with migraine, and over a half of children with migraine have a history of at least one childhood clinical syndrome. And one that's not listed here is travel sickness. So motion sensitivity, travel sickness is seen in over a third of children that have migraine. A third have colic, and then I mentioned the abdominal migraine and cyclic vomiting syndrome. Both of these, they can have, they're associated. So the cyclic vomiting syndrome are these episodes of nausea and vomiting that occur in a predictable fashion, often every 6 to 8 weeks. And the mean age of onset is about 5 years. Now, one thing that's not associated with that is headache is not associated with these paroxysmal conditions. All right, so moving on, let's talk about the phases of a migraine attack, and then it just naturally kind of fit together to talk about migraine pathophysiology at the same time. So migraine attack is an extraordinarily complex phenomenon with multiple phases, and each phase is presumed to have its own pathophysiology. So even days before the pain of a headache attack and a migraine, one can experience premonitory symptoms. So these are symptoms that include fatigue, cognitive changes, neck stiffness, yawning, mood changes, food cravings. And this has been linked to changes in the hypothalamus. And they've been able to show that there are changes in the activity of the hypothalamus days before a headache occurs. And also to think about this, there's a number of foods that were previously thought to be triggers, but are actually, they're part of the food cravings because this has already started in the hypothalamus. I think of dark chocolate as a really good example. So after the premonitory symptoms, about a third of individuals have an aura, and an aura is a fully reversible neurological symptom that gradually comes on over 5 minutes and lasts 60 minutes usually, and it can either overlap with the beginning of a headache or it can be right before the pain starts. And visual auras are the most common in about 90% of individuals. And to be clear, not everyone who has migraine with aura has an aura with every single migraine. And then the classical feature that we think of with migraine attacks is the headache. And so we talked about some of those features, the headache lasting 2 to 72 hours, the throbbing pain, the nausea, vomiting, the light and sound sensitivity. Now, this 72 hours, I don't want you to think that after 72 hours, it's not considered a migraine. It just transitions into something we call status migrainosus. And then after a migraine, after the headache part, one can also have a postdrome. And so these are new symptoms that occur after a headache attack, and they can last 24 to 48 hours. And in youth, they tend to be a little bit shorter, around 12 hours. But look at this timeline. And you could imagine if you're having an aura, the headache, the postdrome, even having a few of these a month could really get in the way of you being able to do the things that you want to do. So let's look a little bit more at each phase. So the premonitory phase, these are the neurological symptoms that precede headache pain. And these include fatigue, neck stiffness, irritability, face changes. For example, a lot of parents will say they see their child looking really pale with dark circles under their eyes. This kind of gives you a sense that something is going awry in the autonomic nervous system. And this has been described in a majority of children. And there's a host of primary literature looking at this, and it's getting more attention. So in up to at least 67% of children in one study described having a premonitory symptom. It can happen hours to days before a headache, and one even said 2 to 168 hours. And these are some of the most common ones that are described. And then I mentioned that this is associated with hypothalamic dysfunction. And there's also a gating mechanism, which is how the brain perceives pain. And so one can actually see a shift in how the brain is processing pain days leading up to the headache portion. And so in this, what they did was they looked at an individual who had episodic migraine with and without aura, and they did imaging of that person every single day for a month. And then they were able to look at what parts of the brain were active the days before a headache. And so consistently, they saw 24 hours before the headache that there was an increase in the activity of the hypothalamus. It's been described in children as young as 18 months, and the number of premonitory symptoms seems to increase with older age and the longer someone's had migraine disease. It's also seen in other episodic syndromes associated with migraine. For example, families can say they can tell when their child is going to have a bout of cyclic vomiting because their daughter or son starts becoming more irritable even the day before they have the nausea and vomiting. And so in this, this is highlighting some of the common premonitory symptoms. And this is at baseline is the darker bar, and at follow-up is the lighter bar. And so over time, a lot of these symptoms become more common and more prevalent. Okay, so let me just pause this. So shifting to the aura phase, the prevalence is estimated about 15 to 30% of individuals with migraine, and it can occur before or during a headache. But in some cases, it can also occur without the headache. And the visual aura is the most common, but there is also sensory auras, speech or language auras, brainstem auras, or even motor auras, which are subclassified as something called hemiplegic migraines. And as I mentioned, not everyone with an aura with their migraines has an aura with their attack. Well, a group at Mayo Clinic developed a visual with a video of what one of a visual aura can look like. And so hopefully you guys can see the screen here. There's a little blurry spot right there, a scotoma that's getting a little bit bigger and bigger over time. And on the edge, you can see there's a little bit of a rainbow. And so, one would see this in both eyes because this is a cortically generated phenomenon. When I take a headache history, I will often explain to my patients and their families what an aura is instead of just asking them if they have an aura, because things like this can be very difficult to describe. And so giving examples of what this can look like or what they might be experiencing could be really helpful to them. And this is something that's been described, back into the 1940s, where Lashley actually published his experience with his aura, and what he drew was something similar to this. So this was the 1941 version of our video. A lot of people will describe experiencing blurry vision with their migraine, and that's very common. But most of the time, this does not meet the criteria of an aura. And part of this is just how much the autonomic nervous system is engaged and dysregulated with migraine. And so it's not uncommon in individuals that have chronic migraine to have, dry eyes. And so that's something you might want to think about managing that could help with pain. So the physiological equivalent of migraine with aura is something called cortical spreading depolarization. And while the migraine visual aura was first described in 1941, it was demonstrated in a rabbit in 1947. And so what I'm showing here is an EEG recording from a rabbit cortex and over time. And so what a cortical spreading depolarization is, it's a slow wave of massive depolarization of neurons and glia. And this is followed by electrical quiescence, so a quieting of the cortex. And this slowly propagates across the cortex at about 2 to 5 millimeters per minute. And so in A right here, we're looking at all of the leads, which are shown here. And this is normal baseline brain activity. And then what you see is this quieting of that activity. So over time, it becomes more quiet and it's spreading along the cortex over time. And then you start to see that activity come back. And so it comes across as a wave. Previously, they called this cortical spreading depression because of just how prominent that quieting is. But during the cortical spreading depolarization, it starts with this huge depolarizing event. And so the acronym stays the same as CSD, but it's switched to using depolarization instead of depression. And so during this, there is a huge efflux of potassium, calcium and sodium come into the cells. There's a release of glutamate, hydrogen ions, and there's also the release of inflammatory substances. And these ionic fluxes are also associated with changes in cerebral perfusion. Now, what I'm showing you up here was done in rabbit, and cortical spreading depolarization has been something that's been captured and demonstrated in individuals that have stroke or individuals that have traumatic brain injury. And until earlier this year, no one had actually captured cortical spreading depolarization in an individual with migraine. And part of that is because the EEG leads on top of a human skull cannot capture that level of change in activity. And so in an individual who had stereotactic EEGs placed, so these are electrodes that went into the brain because they were being considered for epilepsy surgery. That individual had their typical migraine, and we were able to capture that. And so this was a huge change in the field. Another thing is that there's a huge debate about what the role of aura is in the start of a migraine. And there it goes from it is an epiphenomenon to it's the beginning of the migraine. And, I already told you that there are changes in the hypothalamus even before the aura. And so, it's helpful to be aware of some of the debates that are going on, but this is a seminal paper that just came out this year. So let's move on to the head pain and the anatomy of head pain. So, your brain itself doesn't have pain receptors. So all the pain your head feels are coming from the nerves that innervate the covering of your brain and the blood vessels. And in the front, that's largely the trigeminal nerve. And in the back, it's the occipital nerve, which is coming from the C1, C2 area in the spine. And so these innervate the meninges, and then they send information to the trigeminal ganglion, and then it goes into an area that's in the bottom of the brainstem, top of the spinal cord, called the trigeminal cervical complex. And this is very important in migraine, and it connects key brain centers. And so information goes from there to the sensory thalamus and then up into the cortex. And also, it's important to know that there is a convergence of the information from the back of the head, from like the occipital nerve, and the front, all in this trigeminal cervical complex. Now, when we think about sensory nerves, you generally think about it bringing information into the brain. But a major shift in our understanding about migraine pain came from the discovery that there is also the antidromic release from those trigeminal nerve fibers of neuropeptides associated with pain. One of the biggest ones is calcitonin gene-related peptide. And so those fibers contain those neuropeptides, and then they release CGRP. And so then CGRP binds the receptor complex, and then this leads to vasodilation of the blood vessels, mast cell degranulation, and something called neurogenic inflammation. Now, previously, it was thought that migraine was purely a vascular phenomenon, and we've come a long way from that. And it's clear that it's both neuronal and vascular in origin. So this can be really helpful when we think about some of the medicines that we use to treat migraine. So a major one are triptans and DHE. So triptans and DHE, they work on serotonin receptors. And we know that there's a huge role for serotonin receptors in this process. And so what they'll do is they bind to 5-HT1D and 1F receptors, which are on those trigeminal fiber terminals, and they can inhibit the release of CGRP. Triptans also work by causing vasoconstriction and preventing the vasodilation phase. They're one of the major reasons why adults most of the time cannot have triptans are because they have a history of some sort of ischemic injury. And so there's been the development of another class, like dietans, which do not include the 5-HT1B receptors, but still target that presynaptic release of the CGRP and inhibit its release. And so we know that these, the newer medicine is called lasmiditan, and that works on those 5-HT1F receptors. Now, a really exciting thing that's happened in the last decade are migraine-specific medications. And what they do is that they are working on this CGRP pain pathway. And there's two major classes. One are called GPANTs, and the other are monoclonal antibodies. Now, the gepants, like ubrogepant and rimegepant, what they do is they are small molecules that bind to the CGRP receptor complex, and then they prevent the pain molecule CGRP from binding. And these are oral medications that one can take. There's also antibodies, monoclonal antibodies that you take with an injection once a month, usually, that either target and sort of sequester the CGRP, or they'll bind to the receptor itself, sort of preventing this pain pathway. Now, when we think about kids and the acute treatment of migraine, NSAIDs are still our first line treatment, right? We were talking about that neurogenic inflammation, that mast cell degranulation. There's inflammation. And so treating it with NSAIDs is still first line, and we have the most data to support that for children. NSAIDs work better than Tylenol in back-to-back comparisons for treating migraine. And here's the dosing for ibuprofen and naproxen. One of the most important things that I found when I take a headache history is if someone's taking NSAIDs, I make sure that they're taking the correct dose, because one of the first things I'll do is make sure that they're taking the optimal dose to prevent their headache. Now, I also mentioned triptans, and a handful of triptans are FDA approved for children. Sumatriptan, naproxen, which is a combination, zolmitriptan, sumatriptan, rizatriptan, almatriptan. All of these are options. And then the dopamine system also plays a role in migraine with the nausea and the vomiting. And so medications like prochlorperazine can be helpful in treating both headache pain and the nausea component. So let's talk a little bit about triptan selection, because it's helpful to know what the FDA status is. So rizatriptan is FDA approved down to the age of 6, and this comes in an oral tablet, but also a disintegrating tablet, which is helpful, especially if you have a lot of nausea. Almatriptan, sumatriptan, naproxen, and zolmitriptan, these are all approved for children 12 years and older. Now, I don't want you to think that this means that they are, that they would cause any harm to children, because we actually use intranasal sumatriptan in our emergency department. And ironically, intranasal sumatriptan is not FDA approved for children, and it is the most studied triptan in the pediatric headache literature. So things to know about triptans is that if you have an adverse response to one, that doesn't mean that you would have the same response to another. Most commonly, these are sort of heart palpitations or flu-like feeling. And then if one doesn't work, it doesn't mean that another one wouldn't work. And there's also a synergy with NSAIDs. So sumatriptan, naproxen, the combination is FDA approved, but I've never been able to get it covered by insurance, because insurance will say, we'll prescribe them sumatriptan and have them take naproxen. So when we think about the prevention of pediatric migraine, so if a kid is having more than 4 migraine days a month, if they're missing school consistently, that's when we start to think maybe you need to be taking something every day to help with your migraines. And this kind of brings us to one of the biggest studies that has come out for pediatric prevention of migraine. And so there was a trial, a massive trial, that was published in the New England Journal of Medicine 2017, where they compared topiramate and amitriptyline, 2 of our first-line medications, versus placebo to look at individuals that have migraine and see if one was better than the other. And their results, they actually had to close the study early because they found that topiramate and amitriptyline were not superior to placebo. And what all of these children were exposed to in this study is incorporating a multidisciplinary model to manage their headaches. So having optimized acute migraine care, and then talking about healthy lifestyle practices and headache education. And so, it's, clinicians, we still use these medications, but sometimes I will start with something like a nutraceutical, and I'll tell families that the the placebo, they were taking something. So taking something every day can really make a big difference in decreasing the number of headache days. And so why don't we start something which has fewer side effects, like riboflavin or magnesium, and try that before we try a prescription medication. Other things I'll do is listen to the family history, about what medications helped those family members. But the other really big thing is how important diagnosing migraine, teaching lifestyle factors, and actually cognitive behavioral therapy has some of the strongest evidence to help it in youth. Now, a follow-up study that came up 5 years after this looked at that population of kids, and they had sustained positive clinical outcomes even after coming off of the medication. So this is a really promising result that there's a lot of things that we can do to help kids that have chronic migraine. And here is just a list of some of those first-line preventive medications. They're borrowed from a lot of other fields. Like topiramate is something we use in epilepsy, amitriptyline, propranolol, valproic acid. All of these were found to have a benefit, and there's much more data supporting their use in adults. All right, moving on beyond migraine aura, migraine pain, let's talk about that postdrome phase. And so they've started looking into persistent headache syndromes and postdrome. And most kids describe having both persistent and true postdrome symptoms. A true postdrome is a new neurological symptom that occurs after the headache. The persistent ones are, symptoms that they may have had even starting in their premonitory phase. And in kids, most of the time, these last less than 12 hours. Some of the most frequently reported persistent symptoms include asthenia, which is weakness or lack of energy, cognitive difficulties and pallor, and then true postdrome symptoms, thirst, sleepiness, and visual disturbances. These are the most common ones that have been described in kids. And, I want you to think about migraine as a cycle. And so, after that postdrome phase, you go into an interictal phase, and then, and then you start this cycle again. And so this is looking at symptom severity over time. And, even within the interictal phase, we're finding, for kids that have chronic migraine or, they might have residual photophobia during that time. There might be sleep disturbances. We're looking into, what kinds of changes are there to the pediatric brain during that interictal phase, and what can we do to prevent going through this full headache attack. And so I want to think of migraine as more of a cyclical condition. All right, so we kind of went over the phases of the migraine attack and the pathophysiology. And now I want to talk about the future of pediatric headache medicine, because there's a lot of promising things that are going on. And I think that this is going to change how we manage headache in the future. So, I talked about those novel therapeutics, the GPANTs, the monoclonal antibodies, and there are over 16 clinical trials going on in the country looking at these treatments for kids. And some of them are starting to be published in the form of abstracts, and people are using them. In our headache center, we're using these medications, and we're finding that they're very safe. And so this has been these are starting to come out, looking at children with chronic headaches and how they're doing with these newer medicines. And also, the real world use of GPANs, the kids are using them and they seem to be very well tolerated. And I was just at the American Headache Society scientific meeting last week. and one of the largest clinical trials is soon to be published and is published in abstract form, where they were looking at one of those monoclonal antibodies in a phase 3 randomized double-blind placebo-controlled trial in children and adolescents, and they showed that there was a significant improvement in headache days compared to placebo. So to be clear, these are not FDA approved, but these are the studies that have to happen before they even can be. I think another very exciting component is when you treat migraine. So one of the GPANTs, ubrogepant, there is a trial called the prodrome trial. Prodrome is another term for premonitory phase. And what they found is that taking ubrogepant during that premonitory phase, they found a host of individuals that could really accurately say, okay, I start getting neck stiffness, and then I'm going to go in to have the rest of my migraine attack. And treating during that phase was able to prevent the headache pain. And then this is a study that just came out in March, where they looked at other symptoms that are associated with migraine, and they demonstrated that not just the migraine pain, they could also help with some of the other things like photophobia and cognitive changes. And so some of those other features of migraine are being treated, and they're being treated before they even happen. And I think that this is really important for kids and for recognizing those premonitory symptoms in kids, because their headache can last 2 hours. And so an ideal time to treat that headache before the pain hits before it becomes getting in the way of their daily activities is before it happens. So I think this is really promising data, and I think it's going to revolutionize the future of pediatric headache medicine. I want you to also be aware that there are FDA cleared headache neuromodulation devices. And so this is from a review that came out, and these 3 right here, so single pulse transcranial magnetic stimulation is approved for kids age 12 and up, vagus nerve stimulator, and also the remote electrical neuromodulation device. And one of the things about this, and I'm going to talk a little bit about this. So the remote electrical neuromodulation device is a device that one wears on their arm, and it sends an electrical stimulation that one can control on a smart device. And it's supposed to be annoying, but not painful. And so the body perceives this as a subthreshold painful stimulus, and it's activating the A delta and C fibers in the arm, and then it turns something on in your brain called conditioned pain modulation. And so this is one of the ways where the brain releases serotonin and norepinephrine to quiet down pain in other areas of the body. And so, one thing I hear from a lot of parents is a hesitancy to start a daily prescribed medication. And so this speaks to that. There were very few adverse events experienced by kids, and none serious in the clinical trials. And now this is FDA cleared down to the age of 8. And it is not currently, the problem with neuromodulation devices is that they're not covered by insurance. The remote electrical neuromodulation device, given all of this data, is currently covered in a number of states. And I promise you, I'm writing a letter to Washington State every 4 months to try and get it covered. I also want to bring up migraine genetics, because we found that there are over 180 gene variants that are associated with a risk for migraine. And just like we would expect, they include genes having to do with the nervous system and the vascular system. And the more of these genetic variants or risk loci, the younger the onset of migraine. And then we didn't go into a lot of this, but I did mention that one can have a type of migraine aura with weakness. Those are called hemiplegic migraines. And a number of individuals that have hemiplegic migraine have a single gene variant that is associated with their migraine. And so the three that are categorized are familial hemiplegic migraine type 1, 2, and 3. And they're all associated with ion transporter genes. And one that has particular significance to me is SCN1A, which is a sodium channel. It's primarily expressed on inhibitory neurons. And I think of SCN1A because other pathogenic variants in this gene cause temperature-sensitive epilepsies like Dravet syndrome or generalized epilepsy with febrile seizures plus. And so, one of the things that I'm doing with my collaborators, we've discovered a new gene variant in SCN1A that is likely causative of migraine and hemiplegic migraine. And so through a collaborative effort with Frank Kalume, we're further studying this variant. And if one wanted to create a mouse model of pediatric migraine, familial hemiplegic migraine has an early onset, and that would be an ideal candidate. So I want you to walk away thinking about migraine as a lifelong condition. And that a lot of kids that have migraine in youth continue to have that in adulthood. So a logical direction in all of this research is to focus on migraine early in life. And diagnosing migraine early in life can make a huge effect on the morbidity and the experience later on in life. I also think that we need to start having targeted therapies for kids rather than relying on this trickle down method where something gets approved in adults and then we'd go through all of these clinical trials and then we wait for the FDA to approve something for kids. So with that, I want to thank you for your attention. I'm grateful for my department, my colleagues, my research team, and collaborators. Here are just some of the wonderful people. And then I'd like to thank my family. And my son's going through a period where he can't not make a funny face. With that, I want to thank you. And I'm seeing some excellent questions that I would be in the chat. And one question comes up about trigger point injections and whether or not this is an option in pediatrics. So, things that I didn't talk about here today are things like Botox, which can be helpful for chronic migraine. I didn't talk about nerve blocks, which is another way of managing chronic headache or episodic migraine, where you numb all of the nerves on the head and you can't feel your head. In a majority of individuals that have chronic migraine, they also have trigger points. And these are irritated areas in the muscle, in the fascia, where like if you push down, they can really irritate and cause pain. And those can be triggers for having headaches. And now there's a lot more literature in adults regarding trigger point injections, but it is something that people are looking at, and we do them for kids here. And then something that we're bringing to the neurology department soon. I can't hear. Is there a way to unmute?
Hi, Jess. This is Molly Grow. Thank you so much for this fantastic talk and really outstanding work that you're doing in this. From a primary care standpoint, am curious about a couple of things that you touched on and wanted to just hear a little more. One is, when do you recommend riboflavin and magnesium supplements? And could you share a little bit more about the CHAMP results in terms of those kind of, great findings, and that some of the lifestyle modifications are effective? And just from personal experience, I see that with my own daughter who has migraines and with myself who has migraines. So I think I love to know a little bit more about what we can do to help kind of prevent the cascade of migraines for children. Thank you.
Okay. Yeah, thanks for the question, Molly. First of all, this is something that I hear a lot. I can't tell you how many kids I've diagnosed with migraine, and then their parents' face goes, pale, and they say, I've had migraines since I was 7, and no one ever told me. And so, I think there's a huge therapeutic benefit of being diagnosed. And so, I think that that's really important because that can inform therapy. And it doesn't mean that they'll be on medication for the rest of their lives. If you compare it to asthma, they might have exacerbations. For a time, they might need to be on steroids, but there are fluctuations over time, and people can do better, and it doesn't have to have a negative influence on life. And during times of stress, that's when these can happen. So your first question about when do I start riboflavin or introduce the idea of a preventive medication, I listen for things like, are they missing school? Are they having more than 4 migraine days per month? And that could present two ways. If there's someone who has 3-day migraines, they may only need 2 of them a month for me to consider putting them on a preventive treatment. Other things, I listen to how often they're using acute medicines. And all of my patients with migraine, I go to that migraine specific treatment as soon as I can, like the triptans. And so what we want to avoid is something called like a medication overuse headache. Which by definition is 3 months of more than 15 days of headache and using a simple analgesic more than 15 days per month for 3 months, or a combined, like something like Excedrin or triptans more than 10 days per month. So you don't want to introduce a secondary headache. And full disclosure, the data on medication overuse headache in children is nothing near what they have in adults. But those are the big things that I listen for. Is it affecting their lives? Are they using lots of analgesics? And then I also just listen to the families. If I have a family that's very motivated and they said, you know what, as soon as I started the amitriptyline, as soon as I started the topiramate, the parent felt a lot better and made a huge difference for them. I might have a little bit of a lower threshold. Great question. And then for the CHAMP question, I think that we could dedicate a whole talk to, what that can mean for the future of migraine. But I think part of it is the diagnosis of migraine is a huge benefit for kids. And then cognitive behavioral therapy, addressing things like having good headache hygiene, drinking lots of water, getting exercise, trying to regulate your sleep cycle, things like that do make a huge difference. And I would say there are a lot of kids that if we capture them early, we might be able to, prevent the chronification of their migraines.
Wow, thank you so much. We're out of time, unfortunately, but this was a wonderful, wonderful presentation. We really, really appreciate it. For all of you who are here, take a moment to do an evaluation using the QR code. And Dr. Hauser Chatterjee, thank you so much for being here virtually. We really appreciate you. And for our Grand Rounds participants, we'll see you in 2 weeks. Thanks, everybody.
Yeah.